going live, sir. Can I?
Yes, yes, please.
Shut our mouth unless it talks.
Good evening, sir.
Good evening all. This is Chandramohan, physiotherapist. Before I welcome you all for the PGET online coaching session, there is an announcement that we are the first time making some webinar for a social cause. So we request all the physiotherapists to come forward and donate for a physiotherapist. And we will be sharing with the physiotherapist. The whole amount will go for the physiotherapist. One for the hospital bill, another one who lost her life partner yesterday. So we are planning it, to divide and give it to physiotherapists. So this one, even if you cannot afford, there is no restriction. You can register for free also. So we expect minimum 10 rupees, maximum to 500 rupees. In case if you cannot pay, there is no restriction to join. You can put 000 in the payment box, and you can put your phone number or just 129 and add 5 zeros in the transaction number area box, and you can register for this. And the date for payment also, you can put today's date or whichever day you are registering. In case if you are watching it tomorrow, you can put tomorrow's date. So we request everyone to participate in this. In return, we are giving education, in the sense a very good webinar for you. So kindly accept it, and we will move on to the PGET sessions. So I welcome our team members, Rupesh and Tuna, and I also welcome our resource person, Dr. Arun Balasubramaniam, physiotherapist working in the government headquarters hospital, Erode. Sir, I welcome you, sir.
Thank you, Chandra.
Yes, sir.
So
Please
we
carry
start
on.
this session.
Yes, sir.
Yeah, very good evening, friends. And as you know, the same protocol we are going to follow today's session also. As this is the 7th class, and those who attended all the classes know my style. Like we have a few questions as well as followed by some photos, which you are supposed to answer the photos. And, today's session we are going to cover only on the exercise therapy as a continuation of last class. So this time I have put all the photos or the pictures which related to the volumetric measurement, right? The ADL activities, which what is the range of motion? There is no right wrong answers here. All the pictures which you can just try it what is the actual answers. Same as the questions. For the questions, you can type your answers in the chat box. I will check and reply. So we are moving into the first question. Right, so we'll start with aquatic therapy. So immersed body in water experiences upward thrust equal to the volume of liquid displaced. Immersed body in the water experiences upward thrust equal to the volume of liquid displaced. It's the Archimedes principle, Pascal's law, buoyancy, or hydrostatic pressure. The Archimedes principle, buoyancy, or Pascal law, or hydrostatic pressure. Body experience upward thrust equal to the liquid displaced. It's not only the upward thrust, but also equal to the liquid displaced. Please read the question carefully and then answer. Liquid also displaced. So when an object is enters into the liquid, the same amount of liquid is displaced from the water. That is called as the Archimedes principle, right? So only the upward thrust is correct, is buoyancy, but when the immersed body is entered and the equal amount of water is coming, is called as Archimedes principle. I think everyone knows the Archimedes principle, the story behind it. Right? That's why I told, please read the question carefully. Okay, all the following statements are the purpose of aquatic exercises, except, so all the statements are related to the purpose of aquatic exercises, but only one is not there. Facilitate range of motion exercise, Aquatic exercises facilitate cardiovascular exercises. Aquatic exercises facilitate non-weight bearing exercises. Aquatic exercises initiate functional activity replication. Range of motion exercise, cardiovascular exercise, non-weight bearing exercise, or initiate functional activity replication. So read the question carefully and answer it. All are the purpose of the exercises. C, D, C, D. Someone are saying C and someone are saying D, which is the correct answer. Any more guess? So most of them has typed the C, so I also go with the C. Since when you are doing aquatic exercises, it facilitates weight bearing exercise, not the non-weight bearing exercises. Since when you are in the water, your body weight will be reduced. So when you can start doing weight bearing exercises when compared to the land exercise. That's why aquatic exercises are more encouraged for the patients who wants to weight bear or who wants to start doing exercises initially than the land exercises, right? So the facilitate non-weight bearing is the wrong answer. It facilitates weight bearing exercises. It also facilitates range of motion, cardiovascular, as well as the functional activity replications. What are the functional activity? You can do it in the water also. Right? We'll see in the few other slides how much percentage of body weight was reduced, right? Okay, all of the following are the effects of hydrostatic pressure. So all the following are effects of hydrostatic pressure except hydrostatic pressure assists in venous return, hydrostatic pressure centralizes peripheral blood flow, hydrostatic pressure reduces limit effusion, hydrostatic pressure induces tachycardia, which is not the effects of hydrostatic pressure. This is venous return, centralized peripheral blood flow, reduce limitations, or induce tachycardia. Everyone answering D, so I also go with the D. So it doesn't induce tachycardia. Hydrostatic pressure always induces bradycardia. It doesn't help for tachycardia. So other factors are there for the hydrostatic pressure. The venous return, centralized blood flow, reduce the limit effusion, but also induces bradycardia. Say not tachycardia. Right. We move on to the other important question as we discussed in the second slide. When a person immersed till ASIS, right? So when the person, you are making a person immerse in the water till ASIS, how much amount of body weight weighed in the lower limbs? So you are making the person stand into the water till the ASIS, how much percentage of weight bearing in the lower limbs? Is 50%, 25%, 33%, or 15%? Fourth question, is it 15%, 25%, 33, or 15%? 33%. At least please type the answers. Is it right or wrong? No matters. Nobody is going to question why you are putting wrong answers over there. Just make a try so that you can also do the try in the exams. B, A, B, C. Everyone has put good answers. The correct answer is 50% of body weight was weight beared by the lower limbs, and you are inducing into the ASAs. That's why we say in the second question I said facilitate weight bearing. So when you start doing exercises in the water, only the 50% of water body weight was felt by the limbs. So limbs are very actively involved in that. Why it is only 50%? Because of the play of buoyancy. Buoyancy pushes the upward thrust. And here is a picture explaining, right? Till A says it is 50%, till G sternum it is 33%, till C7, till the neck it is 10% only. So body weight was made by the neck is only 10%. If you are going to give aquatic exercises for children or for adults with immersing till the neck level, then the body weight was made by the lower limb is only 10%. So he was able to do all the lower limb activities comfortably without any pain, without any discomfort. Whereas the G sternum it is 33%, ASIS is 50%, right? Please remember it when you are going to train some person in the aquatic training. So this has to be important. And why it is there? Because of buoyancy. Buoyancy helps to make the person to relative weightlessness and helps for doing exercises. Right? Right, we will move on to the next question. Right, it's a photo question. How much pronation required to read a newspaper? Right, when you are holding a newspaper, how much amount of pronation is required? Any cases, wild cases also there. How much amount of pronation required? Right, so to hold a newspaper. Okay, so it is 50 degrees of pronation is required to hold a newspaper, right? So when you are holding, you have to do 50 degrees. I think everyone knows the supination pronation is 90. So we move on to the fifth question. Temperature of the water should be maintained less than dash degrees centigrade to avoid harmful effects, right? So when you are in aquatic therapy or pool therapy, the temperature should be maintained in some degree of centigrade to avoid harmful effects. 45 degrees, 37 degrees, 40 degrees, or 25 degrees. 45 degrees, 37 degrees, 40 degrees, or 25 degrees. Someone says 37, someone says 40, like 37 degrees. Right, so everyone has tried very good try, but 37 degrees is the right answer, right? So why it is 37 degrees? When you are immersing a person more than the 37 degrees centigrade, there will be rise of the heart rate as well as the cardiac output. So this causes severe problems to the patient. So the temperature should be maintained below 37 degrees only. And what is the starting point? The temperature should be between 25 degrees to 37 degrees. Below 25 also it causes lot of cardiovascular changes. So the temperature should be maintained in the water level is 25 to 37 degrees centigrade. So that's why I have put the answer B also to make you to learn. 25 degrees is the least and 37 degrees is the maximum.
लास्ट से नहीं हद तक था तब तक आप पाओगे नहीं.
So we move on to the next question. Question number 6. When a person is immersed in the water till the neck level, right? So I said till the neck level, it is only 10% of weight bearing occurs. But here, there's a decrease of heart rate by dash minute beats per minute. How much of heart rate was decreased when you are in the water level till the neck level? 7 to 20 beats, 5 to 10 beats, 12 to 16 beats, 2 to 6 beats. How much the amount of heart rate decreased or reduced when you are making the person to immerse till the neck level? Yes. It's a very, very good guess, but it is not the right answer. I think one girl has put a right answer. Right, the right answer for this question is 7 to 20 beats per minute. Why there is reduction of 7 to 20 beats? It is because of the physiological changes occurs in the heart when the person is immersed in the water till the neck level. So there was a sudden reduction of the heartbeat, but it doesn't cause any harmful to the patient, right? So because of physiological changes in the heart. Question number 7. Traditional therapeutic pool has a maximal depth of dash feet. So how much is the maximal depth in the traditional therapeutic pool? Is it 6 to 8 feet, 10 to 12 feet, 9 to 10 feet, or 12 to 16? 6 to 8, 10 to 12, 9 to 10, or 12 to 16? Traditional therapeutic pool. Yes, 6 to 8 feet. Very, very good guess. 9 to 10 feet, yeah. Any good answers? 7, 8. B, yes. Many of them have started putting B and they have got the correct answer. So the answer is the B. So this 9 to 10 feet is the right answer because when you are making the person to do maximal depth is 9 to 10 feet. Right. As per the therapeutic pool, the pool should have at least 100 feet in the length and 25 feet in the width. And the depth should be starts from 3 to 4 feet, stopping to the bottom, maximum of 9 to 10 feet. So 3 feet is the starting and 10 feet is the maximum. Right. And the wide is 100 feet and 25 feet is the width. That's why in Indian traditional, we are not able to make a therapeutic pool for our treatment programs since it occupies a lot of space And second, the cleaning of the pool should be mandatory, and it takes a lot of manual work for the people. So that's why we are not interested in doing a hydrotherapy pool for our treatment setting. Many settings doesn't have that. In India, we can number the settings. Those hospitals or clinics or the rehabilitation center which has the therapeutic pools. Right. So goniometric measurement, right? So goniometric reading for the axis of horizontal abduction of the shoulder is greater tuberosity, abdomen process, lesser tuberosity, tip of scapula. What is the goniometric point for the horizontal abduction? So greater tuberosity, lesser tuberosity, abdomen process, or tip of scapula. Very, very easy question. Everyone can put the answer, right? Abduction action, the common point is here, right? It's not you are making the patient supine, and you are making the patient supine, and the axis should be on the abdomen process, and the slings has to be tied up, and then you are asking the patient to do abduction adduction, right? Very, very easy question. And greater tuberosity for the flexion extension. We don't have lesser tuberosity, we don't use tip of scapula. Okay, so other photo question, how much this deviation required to open a jar? Right? How much radial deviation, how much ulnar deviation to open a jar? Any guess? While guess also welcome. How much amount of deviation required? Radial. How much amount of radial? 10 to 20 degrees. Very good. Very good attempt. Very good attempt. So 36 degrees of ulnar deviation, 12 degrees of radial deviation required to open a jar. 36 degrees of ulnar deviation and 12 degrees of radial deviation are required to open a jar. Very good. That's right. Okay, we move on to the ninth question. Grades of orthokinematic movements, motion. Right. So we have grades of orthokinematic motion also. And in that, the grade 2 indicates ankylosis, slightly hypermobile, normal, or slightly hypomobile. Ankylosis, slightly hypermobile, or normal, or slightly hypomobile. What is the grade of orthokinematic grade 2? Slightly hypomobile. Okay. Very good attempt. Very good attempt by everyone. The correct answer is slightly hypomobile. Is a very, very good answer. And those who I think most of them has put D. Very good, very good. So when you look at the tabular column for the orthokinematics, and 0 is ankylosed, 1 is considerably hypomobility, 2 is slightly hypomobility, 3 is the normal, 4 is slightly hypermobile, 5 is considerably hypermobile, and 6 is unstable. So we do the accessory movements of the orthokinematics, like joint play movements, rolling, gliding, sliding, spinning are all the joint play movements or the orthokinematics. When you assess the orthokinematics, you are able to find all these grades, but still it is very difficult. But still you are when you glide the joint, and still you are able to identify it is ankylosed or slightly hypomobile, or normal. But I'll say that it is not like as easy as like goniometric reading. You can do it for 10 patients and then you can find it. You have to do repeatedly to make you master it, right? So orthokinematic movements, identifying the joint play movements requires a lot of skills, and you have to spend with lot of patience. Then only you are able to do accurate movement and you are able to do accurate diagnosis. But very, very good. Everyone has put the correct answers. And question number 10, extension of MCP joint, right? MCP joint of the finger is an example for which type of increase? Soft tissue approximation, capsular stretch, muscle control, or ligamentous stretch? What is the field of extension of MCP joint? Is it soft tissue approximation, capsular stretch, muscle control, or ligamentous stretch? Soft tissue approximation. Soft tissue approximation. C is not there, right? Muscle doesn't control the extension, right? So it's not the right answer. Muscle is not controlling. What else the structure is controlling? Either it is ABD. I said A is also not the right answer. There's no soft tissue approximation. There's very less soft tissues are there in the fingers. Either BD, B or D. And those who put the pat on your shoulders and it is capsular stretch, right? So when you extend it, the further extension was prevented by the anterior capsule, which avoids hyperextension. Tension in the anterior capsule prevents excessive extension of the fingers, right? So this capsular stretch. Okay, length of a small size goniometer ranges from dash inches. In my life, I never measured the goniometer measurement. Right? So how much the length of the goniometer? But still, I have put a question for you. What is the length of a small size goniometer? Is it 4 to 6 inch, 5 to 10 inch, 12 to 24 inch, 8 to 28 inches? What is the length of the small size goniometer? I don't know how many of you measured your goniometer. 6 inch, 5 to 10 inch, 12 to 24, or 8 to 28. Certainly not 8 to 28. It's not 8 inches long. It's very small. So it's between, as you do A or B only, right? So everyone has put B. So the right answer is not the B. So the right answer is A. A is the right answer. The size of the goniometer is 4 to 6 inches, right? Right. Why we want to know the size of the goniometer? Because if you are placing appropriate goniometer only, your measurement will be so accurate. If you are not using the appropriate length of the goniometer, the measurement will not be so accurate. And the larger size goniometer is measured from option D. It is 8 to 28 inches. So that's why I want to put that to understand it. So this picture I have took it from goniometric book, which shows clearly why you want to need an appropriate goniometer. So the first picture shows the goniometer with the 8 inch or 10, 12 inch long, so that it helps to measure the knee flexion extension clearly. Whereas the second picture is a 4 to 6 inch goniometer, where you are not able to measure clearly. You are able to measure some readings, but it is not so much accurate as like the first picture. That's why we need accurate goniometer size. So for the small goniometer size is 4 to 6 inches. And the larger goniometer is what we are using is 8 to 28 inches, right? Some goniometer is 8 and some goniometer is 28 inches. It's an important take-home message today. Okay, so we move on to the question number 12. So dash is designed to measure one plane movement. Supination only one plane movement which equipment is measuring, right? This is rectogoniometer, inclinometer, pendular goniometer, torsiometers, which helps to measure only one plane movement like rotations, supination, flexion. Which equipment? Rectogoniometer, inclinometer, torsiometers, or pendular goniometer, which is helps to measure only one plane. I think the answer, most of you didn't hear that answer. That is the answer for this question. Only one plane. Electrochronometer measures a variety of planes, right? So the inclinometer also helps to measure the spinal movements, right? So flexion, extension, side flexion, lateral flexion, rotations, everything will be measured by inclinometers. So it is not only one plane. So which is only one plane? This option C is the torsiometers. Torsiometers are the type of goniometer which helps to measure only one plane of movement, right? So torsiometers are like screw movements which helps to measure only one plane of movement. Others, arthrometer helps to measure different plane of movement. Inclinometers are mostly used in measuring the spinal joints like cervical, lumbar. Range of motions can be easily measured through inclinometers, and pendular goniometer also helps to measure range of motions. That consists torsiometers, right? How much degree of shoulder flexion required to drink a cup of water? How much degree of shoulder flexion? Or you are going to drink a tea? How much degree of shoulder flexion is needed? This is over high. So in raw basis, how much degree of shoulder flexion is needed? 40 to 45, very good. It's more than 45, right? Look at the shoulder. So it's 38 to 85 degrees, right? So when you want to drink a cup of coffee or when you want to eat, the shoulder should be nearly 90 degrees. Very good cases. Okay, question number 13. Around 3 to 5 weeks of immobilization, how much amount of muscle strength will be lost? Right. So you're making a patient to immobilize for 3 to 5 weeks. How much muscle strength will be lost? Is it 50%, 75%, 25%, or 10%? How much of muscle strength will be lost if it is immobilize the patient for 3 weeks or 5 weeks? 50, 75, 25, 10. How much percentage will be lost? Yeah, 50%. Very good. Someone has put 75. 75, and the answer, correct answer for this question is A, 50%. Right. So when we are immobilizing a patient for 3 to 5 weeks, 50% of the muscle strength will be lost. That's why you should not immobilize the patient, especially if the elderly patient comes with some fractures. Start initiating the isometric exercises, and then once the pain was subsided, start doing the isochronic exercises or range of motion exercises so that to prevent joint stiffness as well as prevent muscle wasting. If you are keeping the joint or the muscle or the bones with the surrounding areas after immobilization without doing nothing, then there will be severe loss of muscle and the muscle wasting cannot be get back, right? So when especially in the whole body, the common muscle which gets easily fatigued is the quadriceps muscle. When you immobilize a quadriceps muscle for at least 2 to 3 weeks, the muscle will become wasting. So you should not immobilize the patient. Whereas when there was immobilization, you have to start doing isometric exercises. Right. So this also is related to the muscle wasting. Like rapid loss of bone mass found in which lesion? Which type of lesion you can find rapid bone loss? Amyotrophic lateral sclerosis, upper motor neuron lesions, muscular dystrophies, or lower motor neuron lesions? Which lesion there will be severe bone loss? Amyotrophic lateral sclerosis, upper motor neuron, lower motor neuron, or muscular dystrophies. All of them will have bone loss when there was the later stages. Initially, when there's a sudden bone loss, we'll see only in one condition, which is the condition. Because the muscles have become weak, flaccid, so the patient was not able to maintain the muscles. So once you want to regain the muscles, it takes longer time. So the patient will weaken. And that's why it is called as lower motor neuron lesions. So lower motor neuron lesions are the common lesions where there is a rapid bone loss, but it's also seen in muscular dystrophy, amyotrophic lateral sclerosis. But initially, you can see rapid bone loss found in the lower motor neuron lesions. Right. Question number 15. Gas fractures are commonly found in osteoporosis. Is it distal radius, tibia, shaft of femur, or head of humerus? Which fractures are commonly found in the osteoporosis? Osteoporosis, more reabsorption. Which bone is commonly got fractured? It's not tibia. Which bone is commonly gets fractured? Is it distal radius, tibia, shaft of femur, or head of humerus? Only 3 bones will get fractures when you grow older, right? So when the individuals are growing older, common fractures you can note it in the 3 bones. Right? I think when you are working in a hospital or when you are doing internship, you are also able to identify the geriatric patients comes with these 3 fractures only, right? So it's very easy to identify. So what are the fractures? We will see that the answer for this question is distal radius. What are the 3 areas you can note it down when in elderly population is? One is the vertebral bodies, especially thoracic vertebral body. Thoracic vertebral body severe osteoporosis causes fractures. Even as a patient will do a sudden coughing, sneezing, laughing, right? So they are able to, their bones were not able to tolerate the stress created by the muscles. Immediately there will be breakdown of the muscle chapters. Second one is the hip fractures. Neck of femur fracture is very common in elders. Slip in the bathrooms, slip by the carpet, or carpet falls, all are tripping by the carpet, all causes fracture of the hip joint, as well as Cooley's fracture, fall of the outstretched hand, which is in the Cooley's fracture. So when you see the graph, this graph is for the postmenopausal women. When you see that vertebral fracture is higher, second highest is hip, and the third is the Cooley's fracture. These common bones are like fracture soon after you are getting older. Right. So deep vein thrombosis occurs in calf muscles. Which vein is commonly affected? Right. We know that DVT is common in the calf muscle. Which is the vein which affected? Soleus vein, gastrocnemius vein, tubular vein, or popliteal vein? Which vein is commonly affected? Soleus vein, tubular vein, gastrocnemius vein, or popliteal vein? I think two veins usually get affected. One is the femoral vein, which I have not mentioned here. Apart from that, which is other vein which commonly involves in the deep vein thrombosis? Soleus, gastrocnemius, tubular, or popliteal. One is femoral vein, and other one is the popliteal vein. Popliteal vein is a common vein which gets commonly involved in the DVT. Right? I think everyone knows that deep vein thrombosis, the common features you can note is the warmth and swelling. So when the patient suddenly develops a warmth or suddenly develops a calf swelling in a prolonged bedridden patient, or the patient you are going to see and you have not seen for 2 or 3 days, and you are going to visit the patient and the patient has severe pain in the calf and swelling is there, massive swelling is there, and you touch the calf muscle and the patient have warmth, then immediately you have to think only one thing, it is DVT. And then what physiotherapist should do? Physiotherapist should do nothing. You should not give any treatment if the patient is diagnosed with DVT, because when you do some movements, this blood clot may travel through the blood vessels. It may go to the heart vessels in heart attack. If it goes to the brain vessels in brain attack. If it goes to the pulmonary lungs, which causes pulmonary embolism. So physiotherapist should not do anything. Immediately report to the doctor or physician or physician. Ask them to do some blood coagulants. Heparin like that has to be given. So the common test, I think everyone knows for the DVT is the Hoffman sign. Hoffman sign is the test which helps to identify if deep vein thrombosis are present or not. It's simply dorsiflexion, you are able to identify. Right, so the picture on how much of cervical rotation need to check a traffic. When you want to check a traffic, your body, your head, and as well as the trunk will move. So how much amount of neck rotation you are needed? Trunk is 50 degrees of front rotation is needed to check whether someone is coming from the head. So how much amount of cervical rotation is needed? 5 to 10 degrees. Okay. 90 degrees, very good. Good, right? How much amount of cervical rotation we need is 60 to 70 degrees of cervical rotation, not 90 degrees. So we're coming very near. 60 to 70 degrees, as well as when you turn it, the body to check it, the trunk should be have 50 degrees of rotations, right? 50 degrees of rotation. Right. So during prolonged immobilization, dash function increases in cardiovascular system, right? All the functions are usually decreasing in prolonged immobilization, but only one thing is increasing. It's cardiac output, stroke volume, pulse rate, or left ventricular function, which is increased in cardiovascular system. Cardiac output, pulse rate, stroke volume, or left ventricular function. Others will not be increased. Only this is increased. Others are decreased. Cardiac output decreased, stroke volume decreased, left ventricular function decreased. Only the pulse rate is increased. So the pulse rate is the right answer, which is increased. Pulse rate, why it is increased? Because of the sympathetic nervous system activity occurs in the lungs and in the heart, which causes the reduction of pulse rate, as well as there was a reduced filling of diastolic with short ejection rate. So there will be reduction of the diastolic filling and the short ejection rate, which causes the increase of pulse rate. Other functions are drastically reduced in immobilization. The cardiac output was reduced, stroke volume reduced, left ventricular function also reduced, except the pulse rate. Okay, orthostatic hypertension, right? Everyone knows suddenly when you get up from the bed and the patient will feel giddiness. It's characterized by a pulse rate increase more than dash beats per minute. So which is called as the orthostatic hypertension. How many pulse rate was increased? Is 40 beats per minute, 20 beats, 10 beats, or 5 beats? So how much is increase in the how much beats is increased in 20 beats? See 10 beats. Yeah, please write the answers. There are 22 students are participating. I think at least 10 answers we are supposed to. At least other 12 are sleeping. So at least 10 answers you can give. Okay, so it is 20 beats per minute. Very good. So most of you are has given the correct answers. 20 beats per minute is the right answer. So when there was a sudden changes, there was a sudden changes from the lying position to sitting position, or sitting position to standing position. There was increase of blood pressure as well as the heart rate. So heart rate is 20 beats per minute was increased. But if it is more than it, you have to consider it to be serious. Like 40 beats or 100 beats was rapidly increased, then make the patient lie again and then give a complete rest. Okay, same question with what is the best treatment for orthostatic hypotension in patient with prolonged bedridden patient, right? All the treatments are okay, right? All the treatments are best treatment, but in hospital we are going to give only one treatment. Stockings, leg exercises, tilting board or mobilization. Which is the treatment we are going to give for the bedridden patients. Because patient was prolonged bedridden orthostatic hypotension, and when you make the patient to stand, he says, "Sir, I feel giddiness. He was not able to stand." So you are supposed to give stockings to the patient. You have to give tilting board. You have to give the fixes. You have to give mobilization. Everything you have to give. But here in this question, which is the correct answer? It can be leg exercise is the correct leg exercise also has to be. I said all the answers are right, but this is the appropriate answers for this question. If the patient is hospitalized and he has a orthostatic hypotension, and you are going to make the patient to stand erect, what treatment you have to do? The first and foremost, you have to give the hospital is the tilting board, right? So using the tilting board, what is use of tilting board? Tilting board gradually makes the patient to stand, right? So shift the patient from supine to the tilting board and gradually increase it. Check the blood pressure before and after, before shifting the patient, after shifting the patient, and then gradually increase the patient and always check the blood pressure as well as the pulse rate using the pulse oximeter. So you have to monitor the blood pressure and heart rate and gradually you can increase it. If the patient will giddiness, if the patient will vomiting, then you have to maintain it. So this has to be gradually treated. Apart from that, the stockings has to be given earlier itself. You have to do stockings, leg exercise, ankle toe movements, vigorous ankle toe movements to be given, and mobilization. Initially, you should not make the patient to prolonged bed rest. Initially, make the patient to start at least walk inside the car, inside the room, or walk in the corridor has to be given. If the patient lies prolonged, if the patient was prolonged bed rest, this causes a lot of problems. Tilting board is the best option in the hospitals. Okay. Very simple question. When the line of gravity falls posterior to the femoral head, so which side the line of gravity falls, and that action will happen. So that's what the basic biomechanics. Which muscle acts to prevent the posterior tilting? So when the line of gravity falls posterior to the femoral head, so posterior to the joint, which muscle act to prevent posterior tilting? Is it abdominals, hip flexors, gluteus minimus, or quadriceps? Which muscle prevent the posterior tilting of pelvis? Abdominals, hip flexors, gluteus minimus, or quadriceps? Simple biomechanical question. Everyone has put the right answer. Very good, very good. Excellent. 20B is the right answer. It's hip flexors because hip flexors only prevent posterior tilting. When contraction of hip flexor causes anterior tilting of pelvis. So excessive posterior tilting was prevented by the hip flexors. Abdominals also will go for weak if it is posterior tilting, and quadriceps doesn't have any role in it. Okay, how much degree of knee flexion required in squatting position? This is squatting position. How much degree of knee flexion needed? Degrees, very good. Very good practice. It's more than that. I also surprised to see 157 degrees of knee flexion is required to do squatting. Very surprised. Because I found kneeling position, kneel sitting is very less compared to the squatting. We'll see that also in the next few slides. Okay, so perturbation occurs as a result of alteration in the visual input called as. So when you ask the patient to close and do the perturbation, what is it called as? Is it support synergy, mechanical perturbation, sensory perturbation, or ankle synergy? What is the perturbation with alteration of the visual inputs? So we just close the patient eye and the perturbation occurs in the patient. So what is the perturbation called as? Very easy question, right? It's like easy ball to board sixers. C, correct, very good. C is the right answer. It is the sensory perturbation. Right? So because visual is a sensory. So close the eyes. Like me, if you remove my specs, I was not able to do properly. Right? Okay. Optimal posture of line of gravity falls to which vertebra? Optimal posture, line of gravity falls to which vertebra? Not the center of gravity, line of gravity. This is S2, S1, L5 or L1. Which posture the line of gravity falls to is S2, S1, L5, L1. D, A, B. S2, S1, L5, L1. I am telling you that one more time also, it is not the center of gravity, is line of gravity. Center of gravity for the human is S2. I'm accepting that. It is not the center of gravity, is line of gravity. Line of gravity falls through the center of gravity. That is, line of gravity is totally different. Next, Yoshita only gave a right answer. It is L5. Archana also coming up with the right answer. It's very good. L5 is the right answer. The center of gravity only S2. Line of gravity falls through the L5. Okay, in sacroiliac joint, the line of gravity falls anterior and creates rotation movements. Like we saw in the hip joint, posterior creates the posterior pelvic region. In the SI joint, it falls anterior, creating the flexion movement. That is nutation movement. Which muscle prevent excessive movement? Which must prevent excessive nutation? Rectus abdominis, iliopsoas, oblique externus, or transverse abdominis. Which muscle prevent excessive nutation movements? Rectus abdominis, transverse abdominis, iliopsoas, or obliques. So anteriorly, when the line of gravity falls, it produces nutation, flexion. This part of the sacroiliac joint. So which muscle prevent excessive flexion? B. C. B, A, B, C, D. Please think which muscle. Certainly not iliopsoas. Right? Iliopsoas with flexion only. To encourage the flexion only, not the extension. So C is not the right answer. Because iliopsoas will help to produce flexion of the hip joint. So it encourages, differently it encourages rotation. So the C is not the right answer. Okay, so we move on to the answers. It is B. B is the right answer, right? So transverse abdominis will work and produces the prevent excessive flexion movement. Transverse abdominis. Right. Excessive dorsal kyphosis caused by compression of which areas in the vertebra? Excessive dorsal kyphosis, that is a thoracic kyphosis. Anterior body of vertebra, posterior body of vertebra, zygopophysializing or spinous process. Dorsal kyphosis caused by what? Which segments gets compressed? Anterior body, posterior body of vertebra, or zygophasic joints or spinous process. A, B, C, D. Before A, yes. I think everyone got the right answers. But those who put that in the chat box are right. Anterior body of vertebra, because when as I told you in the osteoporosis, the anterior vertebral body gets compressed. A small coughing or vigorous coughing or vigorous laughing in the elderly people, sudden compression occurs in the thoracic vertebra, causes fractures or compression occurs in the thoracic vertebra, which results in dorsal kyphosis, especially seen in the elderly people. So there is no relation to the posterior body as a zygophasic acid joints at all. There is no relation. Right answer is anterior vertebral. Okay, in a posture assessment, when you observe a person in the frontal plane, you can notice all the deformities except is it Westplanus, knock knees, kyphosis, or splinting petals. Which deformity we are not going to look into the when you are looking at the patient in the frontal plane analysis. Which is not the deformity we are not going to see that. 25C, kyphosis, A, Westplanus. Westplanus is also called as platform. Okay, I'll give you one more clue. You are going to observe the patient anteriorly. right? So you're making the patient stand in front of you and just observe the patient. What are the things you are going to observe? You observe the shoulder level, eye level, ear level, the hip level. You are going to assess the knee level. You can see patella position, right? And the knock knees are bowed. You can see foot also, flat foot or supinated foot. You can see. The only thing what we are not going to see is the kyphosis, because kyphosis can be assessed through the lateral view. The anterior view can assess eye level, ear level, shoulder level, and the hip level, and the patella knee level, patella position, the foot level, everything we can assess. Only missing is the kyphosis, which we can assess through the other thing. Okay, how much degree of flexion required in the knee? But surprisingly, it is less than the squatting. So how much is that? We have seen squatting is 157, but it's not 157 here. How much is it? Don't see Virat Kohli, I'm asking about the pump. 180 degrees, how it is 180 degrees? Not at all possible in the knee joint, 180 degrees. Surprisingly, it was 144 degrees only. It was less than the squatting. Squatting was 157 and it was 144. I don't know, I just took it from the volumetry book which was written by India Narkins. If you have any doubt, please refer to the book. Okay, so fulcrum to measure wrist radial and ulnar deviation is very, very easy question. Fulcrum to measure radial and ulnar deviation is capitate, trigutrum, scaphoid, or trapezoid. Where is the fulcrum? You are going to keep it for measuring the radial and ulnar deviation. So capitate, scaphoid, trigutrum, or trapezoid. Just click a wrong button and the answer is scaphoid. Everyone has put the right answer. So, sorry, I just click a wrong button. Okay, capitate is where you are going to keep the axis, whereas the movable arm will follow through your middle finger, and the stable arm will be on your forearm. And movable arm to wrist radial deviation, ulnar deviations. Okay, so during the measuring of opposition test for thumb, right? Stage 7 stands for a pulp of thumb contact with the lateral side of index finger, pulp of the thumb contact with the lateral side of index finger, pulp of the thumb contact with the PAP release of little finger, pulp of the thumb contact with the DAP release of little finger, pulp of the thumb contact with the tip of middle finger. This is called as 7. This is called as total opposition test. So what is grade 7 indicates the total opposition test. Is a pulp contact with the, everything is for assessing the opposition. They are going to measure how much opposition the index finger was able to do. This test is called as total opposition test. And just do a wrong, the wild guess, because I don't think you have studied this in your undergraduate. Sorry, this more question beyond your career, right? But still, you please learn this, and it may be helpful for you. Just try, make a try. Okay, you can see the answers. The right answer is pulp of the thumb contact with the DAP release. You see this is a protocol for the total opposition test, and the radial side of the phalanx of the index finger is the 1, and middle phalanx of the index finger, right? Radial side of the middle phalanx of the index finger is 2, tip of the index finger is 3, tip of the middle finger is 4, tip of the ring finger is 5, tip of the little finger is 6, and distal phalangeal crease is the 7, proximal is the 8, and metacarpal crease is the 9, and distal palmar crease is the 10. So this assessment or this scoring is called as total opposition test, which helps to assess the opposition activity of the individual. Right? It was graded as 4 as 1 to 10. I don't think so. It was not in our undergraduate curriculum, but it was given in our volumetric textbook. So I just asked you a question so that you can also study this, and at least you know that there was a test for oppositions, right? Even though you are not able to remember all these things, you just know there was a test for opposition. Right, still 2 more questions only. Patella position in high lateral displaced and faces outside and outwards is called as. When you observe a person from the frontal plane, patella position is higher laterally displaced and face outside and upwards is called as squinting patella, grasshopper patella, patella baja or floating patella. Patella question will be higher and laterally displaced question. What is the name of the patella? Squinting patella, grasshopper patella, patella baja or floating patella. Wow, everyone has the right answer. B is the right answer. It is called as grasshopper eye patella. Why it is called as grasshopper eye patella? Because when you see the grasshopper eye, the grasshopper eyes are on the upwards and lateral. So when you see the patella also moves upwards and laterally because of tightness of the lateral muscles and lateral structures, the patella moves outwards and upwards. It's called as, it looks like a grasshopper eye, so it is called as grasshopper eye patella, which may result in severe maltracking of the patella. Patella maltracking is very common in the grasshopper eye patella. Patient comes with a severe knee pain, and the common management, what we are going to do is the stretching of the patella or the patella mobilization, and then if the patient was severe degeneration, go for some hot modalities. Recentering of quadriceps has to be done. Taping also has to be done. Taping is very good for this condition. Okay, another easy question is the forward head portion. All the statement are good, right? In forward head portion, which is very common nowadays to all the adults who are using webinars, who are attending the conferences, who are using laptops. Our head is going for forward head portion automatically. The head portion is anteriorly, normal cervical convex decreases, abdominal compression of zygopophyseal joints, cervical extensor becomes ischemic, which is the wrong statement in the related to the forward head portion. So head portion anteriorly, normal cervical convex decreases, abdominal compression of the zygopophyseal joints, or cervical extensor muscle become ischemic, which is the wrong question answer here. Everyone has put a big, very good. Studied good about the forward head posture, right? So the normal cervical convexity increases because of upper cervical spine goes to extension and then the lower cervical spine. You can see the first picture, the cervical spine goes to extension, which causes increased convexity in the spine. So this is happens in the forward head posture. You can see the normal posture, the forward head posture. There was an increased convexity. The head posture is also abdominal. Because of this, there was a stretching on the anterior muscles, compression, that is hypertrophy occurs in the posterior muscles, which results the cervical extensor muscle become ischemic. So once there was a stretching occurs in the anterior muscles, becomes overstretched, atrophy occurs in the anterior muscles, hypertrophy occurs in the posterior muscles. This in turn is called as the upper cross syndrome. So the patient comes with severe neck pain and you do assessment and find out which muscle tighten, which muscle weaken. Stretch the tighten muscle, center the weaken muscle. That's what we do. I think everyone has put the right answer for this question. So someone can put the wrong answer. The last question for today's session, the ideal number of participants for group therapy should be 8 to 10, 10 to 15, 15 to 20, 20 to 20. What is the ideal number of participants for group therapy? Group therapies are done for variety of conditions. Nowadays, the COVID patients also, post-COVID treatment also, we are starting group therapies in some hospitals. Group therapy is very good exclusively in conditions like post-cardiac surgery, CMPT surgeries. Group therapies will give excellent results. And many of the Western countries also doing group therapy for osteoarthritis of knee joint, shoulder, PA shoulders, and all, they started doing group therapies, right? So if it is a group is very less only, you are able to control it. Right? So if a longer group, you are not able to control it. So if a group therapy is a separate class, you have to take a 1 hour class for group therapy also, right? So you can read it in variety of textbooks, but no textbook have a good messages given about the group therapy. That's the sad part of physiotherapy. And many of you put the right answer A and answer B, but the correct answer is answer A is the right answers. Postnatal woman, prenatal woman, like antenatal classes are conducted, and group therapy for the cardiovascular surgeries, post-cardio CAPG surgeries, and group therapy now it was recently started for the COVID patients, post-COVID patient with a severe lung function, lung constrictions, they started group therapy. Right, excellent. So that's it for today's session, and the last picture of today is how much hip flexion required to sit in a chair. So it's become a habit I put superstar assuming progress. Knowingly, unknowingly it was coming. Right? How much degree of deflection required to signature? 90 degrees, okay, 85 degrees, 90 degrees, very good. This 112 degrees at least needed to make the patient signature. Very good. Good attempt by everyone. So that's it for today's session, and you can find a lot of questions, MCQs in my two of my textbook which has written. That's it for today. We will meet you next class, and my next class is on the exercise therapy part only. As I told you before, we have exercise therapy, the whole part of this month, right? I think till next two classes also we have exercise therapy only. The last class we have massage also. We are planning to give some questions on the massage. The next class I'll put this in the group WhatsApp group, share it in the WhatsApp group, and
Yes, sir. Yes, sir.
absolutely. And I can also share this week question to Mr. Chandra, and probably he will help you to post it, and you can find the answers. So that's
And
it for today.
dear
Thank you very much.
start preparing. We are planning for a mock test. There will be some 100 questions to be given, and you have to log on to our website, or we may make some other arrangements. So within 2 hours, you have to answer all the questions, and you have to finish answering all those questions in 2 hours. So be prepared.
The questions, yes, sorry to interrupt. The questions will cover all from your physiotherapy, starting from the anatomy till your rehabilitation medicine. It will be covered. After neuro, cardio, exercise, everything will be covered.
Bachelor of Physiotherapy subject.
It's not
Yes,
for
sir.
masters, not for masters.
Yes, yes. Thank you, sir. Dear participants, do you have any questions to discuss? If you have any, just kindly take few seconds and raise a question in chat box, or you can unmute and ask our resource person. Let me check.
So the normal knee range is only around 140 to 140 degrees or something. There was in that one question where you said the knee range will be around 154. Sir.
For the squatting question, it was told that it is like 157. That's why I was also really surprised, because kneel sitting was they have put less degrees, 144 degrees, but for squatting it was given as 157 degrees. The normal range of motion for the knee joint is 140 to 151. So I have referred the textbook of goniometry based Indian knowledge. Can also refer to the online textbook also.
Okay, sir. Thank you, sir.
No questions in YouTube, sir. And most of our participants were answering enthusiastically. So we are thanking for them. And thank you so much, sir. Good night. Hello.
Hello, sir.
Yes, sir. Thank you, sir. We will finish.
Yes, shall I wait or I go off?
You wait, sir. You, sir. I request the participants to leave. And Duna, madam, you can stop our YouTube connection, please. Duna, madam. Rupesh. Rupesh, are you there?
This is not here. It's missing.
Duna, madam.
It's also not here.
Just wait, sir. Just wait.
No problem, Fabi. You have some other class, right?
No, sir. No, sir. We have to. He left actually. Duna, madam. I don't know whether it is going on live or not. Let me check once. Hello, sir. Both of them are not available, sir. We can wind up now. I will call you, sir. Actually, Arun, sir. Hello.
I have muted it, sorry. I have WhatsApp the questions to you.
Yes, sir.
Please check it, no problem. And
Yes,
I'll
sir.
also send the question what I want to ask to you, and you can ask it
Yes, sir. Yes, sir.
later. No problem, there's no hurry. It's only
Yes, sir.
9:20 today. We have still, when we are planning to conduct the exams?
We will plan, sir. Actually, we will plan. We will fix a date, and I will also make a flyer. I think we are still on live. Actually, I will close the live and then I will make a
Okay,
call.
okay, okay. Bye, 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 bye.
Yes, sir. Bye. Thank you.